Hello everybody and welcome to our most marvelous and exquisite session on combined vision and hearing loss in long-term care, interprofessional contributions to integrated care to address sensory-based communication barriers. So today we're doing exactly the opposite of what we've been doing on some other days. We talk about old people instead of talking about young people. Yeah, we need a little bit of spread around of all the topics. And I am going to figure out how to change this here. Hang on a second. I can tilt it up? Ha! Magic. There we go. This is it. Excellent. So, welcome to the session. I will be moderating. I'll be walking us through the adventure. One of the pieces that I need to point out right away, is that this is a session that is 1 hour and 45 minutes long. So this session goes through the break in between the sessions. This is a unique session this way. It's the only session that is longer. It is because of this that I understand if people suddenly come and go in the middle of things. This also means for our speakers, there may be some people joining us later because other sessions have a gap in the center. I will introduce all our speakers as we go forth, but I'm very, very excited to welcome Marilyn Reed, Kathy McGilton, Atul Jaiswal, Michelle Wilchesky, and Kathy Pichora-Fuller for our panel today. I have excuses today for JB Orange, who is not able to attend because of a family health reason, and I will explain 2 other speakers we're missing for other reasons beyond our control, but then you get to listen to me a little bit more in the process. I also quickly want to put up a land acknowledgement, and in case you don't know the website of Whose Land, it's a very interesting place. I encourage you to check out this website. You will learn interesting things about how you could divvy up land. So, like I pointed out, this session is longer, it's different, and it's weird. And that's just how we are. So there. We have a lineup of exactly. We have a lineup of exquisite speakers that I will walk us through as we go forward. I want to point out that our last speaker, Kathy Pichora-Fuller, is here to be our discussant. So we're actually giving relatively short presentations. They're all around 10 minutes. I've already whipped my team into shape that 10 minutes is their limit because it will give us more time at the end to engage with each other a little bit and to discuss the topic of long-term care and sensory loss. The first person who's not here is the lovely Paul Mick, and so I get to replace Paul in our perspective of interdisciplinary and multidisciplinary work. Paul on our team is an ENT, an ear, nose, and throat doctor, is our token medical representative that every team should have. But Paul has a really wonderful perspective about hearing care and social participation. And I find it very interesting how he integrates the need for social variables into his approach to hearing care as a medical professional. He spends his time and his life implanting cochlear implants, but does all things medical. And so he also is our public health and big data guy on the team, and he has put together some information that is based on the Canadian Longitudinal Study on aging. So I will be presenting some of the work that Paul has put together for us today. If you're not familiar with the CLSA, the Canadian Longitudinal Study on Aging, it's a very large cohort study that is now, I believe, in the process of collecting its 4th wave of data, so it's already been going on for quite some time. There are different cohorts. Some people are followed only over the telephone. Some people are followed in person. That would be the comprehensive cohort that I'm talking about today. And so we have quite a bit of information about these people that all, when they entered the study, were between 45 and 85. And they're now being followed for 40 years in order to then have 85-year-old data on the 45-year-olds that started. There are measures of vision and of hearing in these data, both behaviorally, as in, for example, doing an audiogram or completing an acuity chart, but also self-report data. I'll get to that in a moment. And it's an extremely comprehensive data set with thousands of variables that I don't have time for, but it's a wonderful Canadian context data set. Now, when we look at the hearing data, it is not entirely surprising that audiogram, in this case, impairment, you can see the milder impairment in the upper lines, that is 25 decibel hearing level for audiograms, and the more moderate impairment is at the bottom with above 40. So that is usually the way the data will be divided into mild and moderate. If you have access to color, the blue information is males, the red information are females. And we have here, as you see across age on the x-axis, you can see how prevalence of hearing loss goes up as participants are older. You see exactly the same thing for vision impairment. So now if we look at our interest group, let's say at around 80, you will see that about 60% will live with a mild hearing loss, and about 60% will live with around a mild vision loss. If you look at the moderate to severe level, we're around 20%. Now, these data are considering things separately. And of course, I always am after every epidemiologist to combine these data, and this is not always obvious because they are often collected separately and then not integrated. But here we can, and so it turns out when we look at dual sensory loss in the 80s group, we're roughly at 20% of the population that live with both impairments together. For the ladies in red, and around 50% for the gentlemen in blue. So these numbers are potentially higher than you might have expected, but I think it's a great data source for us to justify the importance of looking at this context. Now, something that I find really interesting is that we can compare the subjective and the behavioral data. So what we have here is different squares for different age groups. So the 45 to 54, the younger ones are at the top left, and then the oldest ones are at the bottom right, over the age of 75. On the x-axis, you have their personal report on whether their eyesight using glasses, in this case, is excellent, very good, good, or poor. Right? So as you go across the x-axis, their perception of their vision gets worse. On the y-axis, though, as we go up, we have their visual acuity. So as we go up on the y-axis, their vision actually is poor on their acuity charts. So something interesting happens. You have people that tell us that their vision is fair or poor or non-existent, but on their visual acuity measure, they are doing well. Right? So this is a bizarre contradiction here, unless, of course, you have a visual field impairment, right? Because that would not be caught here. And then you've got people that tell us that their vision is excellent. But when we actually measure their acuity on an eye chart, they have moderate to severe vision impairment. They are even, these people in the green boxes are even eligible for rehabilitation services for their vision impairment. So what it really drives home for me is that these are two separate things, and that these are things we need to consider together, because these are separate stories. What we measure and what people experience are separate from each other. And the true story really is in the overlap of those two. When I look at the report and the measurement of dual sensory loss, we see something similar, that the measurable dual sensory impairment increases exponentially with age, but the self-reported version of dual sensory impairment doesn't. And this is a little bit counterintuitive, but it happens. There's something bizarre happening around age 60, that up until age 60, the measures of the behavioral measures underestimate the perceived impairment. The perceived impairment is actually higher. And then when you go over the age of 60, this reverses, that the perceived impairment is actually lower. Now, I put those in quotation marks because I can't tell you which one of those two would be the gold standard, because either one of them could really be right. Who am I to judge what you perceive or what I measure? Both of these could be very valid, but they probably just need to be considered together. Paul has also put out some data for us when we now look above and beyond vision and hearing, and it turns out that the proportion of people with 2 or 3 impairments, in this case we're looking at poor balance, for example, this proportion goes up with age as well. Especially, again, we're interested in what happens at age 80 in the context of long-term care, and so having 3 impairments is really starting to pick up at this point, right? And I think for anybody who works in this context, that is not going to be a surprise. Now, if we look at people with vision loss specifically, they are more likely to have other deficits independent of their age or other risk factors. So what you see here is the people that live with vision impairment are in the dark blue bar. The people without vision impairment are in the light blue bar. And so you can see that the dark blue bars are higher if you look at people that also live with a hearing loss or people that also have poor balance. So there are some bizarre and very interesting associations among the impairments, that if you have one, you're more likely to develop or have another. And it goes beyond just vision and hearing. It goes also into balance, for example. And when we now flip this, yes, we can measure this, but when we then ask you about your self-perceived rating of your general health, of course, it is understandable that these health ratings are negative if you live with 1 impairment, which are the 3 blue groups on the left. But then if you look at the combination of impairments, the self-ratings go down further. And they are, of course, the worst or the most intensely negative if you have all 3 impairments in this case. So it's not just an observation, but it's also a perception that comes with this. And something that is very interesting in our team that we are often looking at is, of course, cognition as well. And it turns out that when you look at sensory impairments and their link, in this case, to executive function and to memory, dual sensory loss is associated with larger impairments in cognition in this case as well. Now, that's the story that Paul would have told you if he would have been here. And we have a note coming to me. There are visually impaired attendees in the room that do not know what I'm talking about. That's very good. We will come back to this in a moment. As I go forward, I will be more visual in my description. So the second speaker that we're missing today is the lovely Dawn Guthrie, who also, for reasons beyond her control, could not come to the presentation today. Dawn is at Laurier University, and she is our big data lady. She knows how to manage large data sets that are way beyond my control. I will tell you in a moment what she does. And so she works with the interRAI healthcare assessments. Just a curiosity for show of hands in the room, how many people in the room know about the interRAI measures or have laid their hands on, have heard of this? Up more or less half. So I will tell you a little bit about it. So the questions that Dawn wants to answer in today's presentations is what is actually the prevalence of dual sensory loss in long-term care, specifically in the access to data in Canada. How does this compare with other countries? Because the beauty of the interRAI system is that it is used globally. And then one is some of the characteristics that differ in people with dual sensory loss in long-term care versus those people that live without dual sensory loss. The interRAI is an interesting way of what I call a third-party assessment. So it is not a survey, but it is an assessment that is highly standardized, whereby people undergo several days of training in order to administer this measure in a comparable way, no matter where you do this. So this is, it's not just a questionnaire that you print out and you go, but you're actually trained to do this. This is often done by health professionals, nurses, occupational therapists, other people that are working in the system to administer these questionnaires. They are widely available. However, these are measures that you need to pay for, which makes them a little tricky. I really like the interRAI measure, of course, because it has a specific deaf-blindness supplement, but it is not something that you could simply photocopy and use because it is part of a larger assessment system. It's used all around the world. It's also very funny because I'm a big interRAI fan, but I work and live in Quebec where it's not used. So even though we have a validated French-Canadian version of it, but it hasn't yet made it into the Quebec system because we have something similar that was created separately. There are multitudes of these measures. They all have a same underlying structure. And then, things are scored from 0 to 5, from 0 to 10, depending on what the interest of the item is. And the items themselves within the questionnaires then have specific goals to assess various aspects of functioning. And there are specific measures that are developed and used in the context of long-term care. So like I said, it is a clinical assessment tool. It is not a survey. It is done in the shape of a conversation. If this is an intake kind of situation, for example, you don't just follow the order of the questions. You may actually extrapolate information for items that are mentioned later on already early. So this is why you are highly trained to do this, because you don't just follow a menu, but you have to integrate this information. Something else that is fascinating is that the data sources can vary. You can include family members and care providers at data sources, the staff, or you can go into charts and files in order to add information. So the assessment is as global and inclusive as possible. Like I mentioned, it is used in multiple provinces, though not all in Canada. Not every province will use every measure, but that is relevant today because we're specifically looking at the long-term care measure. But we have over 1.5 million assessments that we can work with in this, which now explains why Don has a very special skill set to deal with this kind of data. So here is how vision is measured. The question is the ability to see in adequate light with glasses or with visual appliance normally used. So we are looking at the functional ability of this person. This can be somebody with visual impairment. If they are properly rehabilitated and have the tools they need, they may actually have adequate functioning, right? So it's not, we're really looking at the level of impairment that is possible or that is observed. It can be adequate, which gives you a 0. It can be moderately impaired, which means there's limited vision, not able to see newspaper headlines, but can identify objects. 2 would be highly impaired. Object identification is in question, but the eyes appear to follow objects. Or 3, severely impaired, there is no vision or sees only light, colors, or shapes, and eyes do not appear to follow objects. So you see that there are sort of brief definitions, and if you go into the training manual, there is actually much more detailed information available to define each item. Similarly for hearing, the ability to hear with hearing appliance that is normally used. I love the phrase normally used because many of you know that people may own something that they don't use necessarily. It could be adequate for a 0. It could be minimally difficult, which means it requires a quiet setting to hear well. It could be hears in special situations only. The speaker has to increase the volume and speak distinctly. Or for a level 3, it's highly impaired. There is no hearing that is useful in any way. So those are the standardized questions in the interRAI across all measures of the interRAI. How vision and hearing are assessed. If anyone has a score that is higher than 0, so 1, 2, or 3, in both the vision and the hearing context, they are considered, in our case, to have a dual sensory impairment. So even if you're mild in these impairments, you are included in this analysis. It's also that in the home care measure, for example, that is what will trigger the deafblind supplement as an assessment tool. Here are some prevalence data for the Canadian context of interRAI assessments in long-term care. What is the prevalence of dual sensory loss? In the Maritimes, 15%. There are no Quebec data, as we don't use the measure currently. In Ontario, 24%. In Manitoba, 25%. oh, look what, where am I now? Wow, geography, Canadian geography after 4 days of conference. Manitoba 25, Saskatchewan 24, Alberta 32, British Columbia 24, and then we do have Yukon data at 34% as well. These numbers differ somewhat from each other. I invite you to have beverages with us after the panel to discuss why that may be. Some of this may be good reasons, some of this may be bad reasons. It could be that in some regions people stay in home care longer, which would not be captured here. It could be in some regions it is only that you are admitted into long-term care if the situation is more dire, which would be why the numbers might be higher. But right now we are still in the process of untangling this. If we now look at these groups of people with dual sensory loss and compare them to those who do not, so we're looking at roughly 500,000 people compared to 75,000 people. People with dual sensory loss are more likely to be older, or in this case over 85. They are more likely to need help with activities of daily living such as dressing. They are more likely to have a distressed family caregiver. I think that's an important piece here. They are more likely to have symptoms of depression, even though actually this percentage is not that much higher. And they have more difficulty understanding others, which is, of course, intuitive. So comparing the Canadian numbers across other countries that have used this assessment, again, you see some differences in the prevalence. And again, some of the reasons may be hidden in bizarre places. But keep in mind, these numbers cannot currently represent the entire country, because in all of these places, the long-term care measure is not used systematically everywhere. So this really only represents very specific regions with each country. So this is Dawn's story, and that lets me off the hook now because I'm really just supposed to moderate. So you've seen way more of me than you actually thought you would. So I will now hand things over to Atul, who joins us from the Briere Research Institute. Oh yeah, come on over. Who joins us from the Briere Institute here in Ottawa. He's worked with me as his postdoctorate for a while, and has done some interesting work at that period that I will hand over to him now. Thank you, Atul.
Thank you. Thank you, everyone. Is it audible? Good? So this is my story now. I will be talking about, based on my postdoc work that I did with Dr. Walter Wittich. I'm currently at Briere Research Institute, but I'll be coming back as a postdoc again sometime in November to continue the work that we have been doing. So I would like to acknowledge my funders, research partners, I think without whose support this was possible. So they are here. So I think we have been talking about DSI, and you all know that it is more disabling and complex condition. So than single sense impairment, be it hearing or vision. I'll not go there because I think we all know about it. So, and this was already covered in this the previous presentation about the prevalence that was reported and their difficulties that they have, older residents in long-term care with DSI. So, and then we wanted to understand what is happening to them. But overall, my journey was trying to understand older adults with DSI and their experiences with respect to healthcare access during COVID-19 pandemic. So, because I believe their stories were different. Everyone was impacted by COVID-19, but people who have sense impairment and dual sense impairment, they might have different unique challenges that we might not aware of. So that's what pushed me to do my postdoc work, and this was what I did. So first was a systematic review that got published, and the paper is there out. I'm happy to share that paper with all of you. We found 26 studies that were there, which were talking about different tools and strategies that are there, that are specifically about dual sensory loss care with respect to continuum of care. So that was the first paper that I sort of got out of my postdoc work. Then there was a second study which was more about understanding the stories of older adults with DSI from Quebec and Ontario, and the stories of their caregivers, be it a family member, friend, or volunteer who is helping them go and access care. So some of those people who you see here, they had someone who was in long-term care as well. And then we had online survey with healthcare professionals, 229 healthcare professionals across Canada, starting from doctor to frontline staff, like personal support workers. They all participated in this study. And out of that 229, I got data from 37 healthcare professionals who belong or who are working in long-term care. So that's what this particular presentation is based on, all these small data set that I got from long-term care specific work. And then out of this 22, the 22 qualitative interviews that I was able to do was from the subset of the online survey study, people who agreed to share their stories more than just what was given to them on the survey question. So out of these 22, 6 of them were working in long-term care settings. So my story that I'll be presenting in subsequent slides is all about the data that I've got from there. So this is systematic review. I got only 5 studies, and that's a very unique thing that because there was no limit applied on the search strategy, like there was no time limit applied. So I only found 5 studies. I did my best to find everything that is out there, but I could only find 5 studies that were talking about any tools or strategy that could help providing dual sensory loss specific care in long-term care setting. And those are listed here. Again, interRAI we already talked about, so I'll not go there. But that's a very unique tool, but it is paid, so that's what maybe access to that particular tool would be limited. Screening program, this was Flynn in New Zealand. So they did a study trying to understand screening program to identify communication difficulties that older residents with DSI might have. So that was, and then they came up with the communication skill training. But all these studies are still, I believe that I'll say their initial stage, a lot has to be done further. So maybe this is a very nice gap that my systematic review was able to pinpoint, that we need more studies in the context of long-term care, or even I'll say overall healthcare itself. Then there was a Haycuttle study that was done in Flynn. Yeah, Haycuttle was in US. So this was screening program for sensory impairment in older residents with dementia. So this is also a unique study to sort of go and read about if you're interested in long-term care work. And then there was a severe dual sensory loss screening tool that was developed by Roth-Merkin et al. And colleague in Netherlands. So that's what I could find. And then they also had a self-management program for long-term care residents with DSI. So these are only the 5 things that I could find from the research literature that is out there that could help us as a practitioner or who is working in this space of long-term care to improve their care for older adults with DSI. Now going back to my other 3 studies that I talked about. So again, from the survey data of like 37 professionals who shared their data, and then 6 professionals who shared further their data like from the qualitative interview, and then some caregivers who had someone in long-term care home who had DSI. So based on all these studies, all this sort of data, we found 4 main things that came out. First one was identification of dual sense impairment among older residents with DSI in long-term care home. So imagine during COVID-19, we all know that masks were there, personal protective equipments were used. So there's an older resident in long-term care home who might have a DSI, and then there's healthcare professional, be it a doctor, nurse, or a frontline staff, trying to communicate with them. If the DSI was already documented on the medical chart, then life is easy that they know that this particular person might have dual sense impairment. Otherwise, if that is not reported there, and it's very common that these older adults or residents who are in long-term care home, they are there in long-term care home because of other complex healthcare needs, not because of DSI. So it's very much possible or likely that might have been overlooked or missed out. So that was a big concern. Suddenly, when personal protective equipments were used, it was a bit of a challenge for all these healthcare professionals that were there. Healthcare communication, lip reading was gone, like that could not be used anymore. If people are using hearing aid, and maybe if the hearing aid and every sort of device that was being used or that could help healthcare communication that was not properly maintained, that was again a problem for all. So healthcare communication was compromised and almost all those 37 professionals who I sort of got the data from, they shared that experience that was very, very challenging. Oftentimes, they have to sort of do their own innovative strategies to figure out what is going wrong. Why I'm saying something and then the person not able to respond back. So then they ask person to respond back to check whether the person is able to understand it or not. So they realize that there is something going on more than the complex healthcare need for which this particular person is here in long-term care home. So that was a big concern. They shared stories about limited resources. We all know that like nursing homes and everywhere healthcare system was, I'll say, overburdened, and they had shortage of staff. So that was a big concern that was shared. But I think people have survived, and I'd say that yes, we are a little bit out of the COVID. That's helpful, but I think we need more resources with respect to providing dual sensory loss specific care in long-term care homes. Technological issues, though people were able to use technology, like iPad was used, Pocket Talker is another technological device that was used, and that helped in healthcare communication and interacting with this older residents with DSI, but still, whether everyone is trained to use that, and whether the older residents who is there, they are trained to use all of these technological devices, that was a major concern. So, and because we know that COVID happened suddenly, March 13, the whole world changed, March 13, 2020, the whole world changed and everything was sort of in a different way. Telehealth was introduced and everything was introduced, and all these people who had sensory impairment, maybe their stories were somehow missed out or were not considered when they were thinking of providing care. So what can be done? So maybe I'll start with a very basic thing, which I think every practitioner should be mindful of, is all about focusing on environmental accessibility. It does not require money. It's more about ensuring that you have adequate lighting in the room, there's no clutter in the room, you minimize the clutter, you ensure there's no background noise. If you ensure all these things, I think the communication could be improved. And I think that's the first essential element of providing better care to older residents in long-term care homes. Accompaniment, I think, was a very strong element. Like before COVID-19, everybody, like family members were allowed, friends were allowed, volunteers were allowed to be with these older residents in long-term care home. And suddenly with restrictive, like the visitation policies that change, things change overnight, and then they were not allowed. So now the healthcare provider and the patient is only sort of two parties there, and they're struggling on their own to figure out how to communicate with each other. So I believe that could be one main thing that we need to also sort of reinforce this message that yes, it is good to have someone there. I'm not saying that the person needs to be there to communicate everything between the two parties, but there has to be someone who could understand, who could document the healthcare journey of this older resident with DSI, and who could be a ally in the care process. And then interprofessional collaboration and coordination, that was very strong component. We could see that a lot of, there was a turnover was very fast. So a lot of staff were coming into the long-term care and then they were going elsewhere. So a lot of new people were coming into the system during COVID-19. And if they were not trained and if they have missed out on DSI, it was a challenge for them as well. Like they have a very short window of time to do what they are supposed to do, be it a doctor or a personal support worker who is there to just do basic stuff of activities of daily living for these older residents. But if they are not trained, they have not seen, I believe our eyes will only see what our brain knows. So if you have never understood this concept of DSI, or if you have not seen any person with DSI before, you might not be able to identify, though it is right there in front of you. So I think that's the first starting point. And from my data, people shared that if they had even one chapter or one session, one lecture during their medical training or during their course that they got to expose to this DSI concept, they were very smart in their way to understand what could be done. But if you missed at the right stage, it's gone. So a lot of people who had understanding, they were able to share their knowledge and experiences with people who are not sort of exposed to the DSI people, sort of people who had not training of DSI, and through that sharing of the knowledge that helped. Use and maintenance of assistive technology, it could be simple thing like hearing it could be a cochlear implant, but all these things are there, and how to improve, how to sort of ensure that they are maintained properly. Training on DSI specific care, I think this is what I sort of strongly say, and I think we all need to advocate that our healthcare professionals need to be trained exclusively on DSI, even a little bit, but we need to start somewhere, and I think this is a time to do it. Some of the references, I'll stop here. Thank you.
Thank you. So you will see as a theme that we're going to push all our questions to the very end because we have an exciting discussant at the end. But you will also clue into the fact that one of the reasons why we have so many speakers, including Marilyn Reed that's joining us now, you will get different professional perspectives. Atul, being trained as an occupational therapist, has a different lens through which he views the situation. Now, over to Marilyn for the audiologist.
Thank you very much. Much shorter than Walter, so I have to. Can you all hear me? Okay, so I'm an audiologist, and I work at Baycrest, which is a large geriatric center in Toronto. My experience has mostly been with older adults with acquired hearing and vision loss. So for an older adult with hearing and vision loss, moving into long-term care is pretty much a recipe for social isolation. And if you add to that the pandemic and the restrictions that the pandemic introduced, then it's pretty much a perfect storm of risk factors. But for a given level of hearing and vision loss, there are different levels of functional ability that depend on other factors like the environment and communication partners and how skilled they are in communicating. And so it also depends on the cognitive status of the person and what their cognitive resources are for compensation. And also how motivated are they to make that effort to listen and to continue to try to participate. But when demand exceeds capacity, as it frequently does in long-term care, then they just stop trying and give up. Despite being very common, I think more common perhaps than some of the interRAI data suggests, because it is based on self-report, dual sensory loss and especially hearing loss, because it's invisible, often goes overlooked and unmanaged in long-term care. And there are many barriers to communication access, including lack of awareness of the presence of hearing loss. And I really think that we, as I said, because self-report really doesn't identify it as often as perhaps we should. Also, limited access to hearing services, and that was certainly exacerbated by the pandemic. The cost of services and devices, which often include expensive hearing aids. The fact that many long-term care residents have multiple comorbidities that make using technology like hearing aids very challenging and means that they're more dependent on staff, which makes caregiver knowledge so very critical. Today I want to focus on some interventions that we use at Baycrest to address these barriers. And the first one is screening for hearing loss. And I don't have time to talk about that much today, but we are doing some form of measurement wherever possible on admission to long-term care, which certainly indicates that the presence of hearing loss is very high, in over 80% certainly in residents in long-term care. But we also need to look for reversible causes, and one of my big beefs is the fact that wax gets horribly overlooked. It's a very common problem in long-term care, and unfortunately, very often nobody looks in ears, and certainly during the pandemic when physicians weren't coming into the facility, it was definitely getting overlooked and causing huge problems. It was a demonstrable problem during COVID. We also need to make sure that technology is appropriate for people's needs and abilities, and that we use technology as much as possible. And that people are educated. Rehab includes not just technology, but certainly includes educating people around communication, behavioral communication skills, and also environmental modifications. And providing accessible opportunities for social engagement as well. We'll talk more about that in a minute. So during COVID, did anything change? Well, certainly the challenges were exacerbated. There was increased social isolation, and precautions like physical distancing and mask wearing and remote care had certainly a big impact on communication difficulties. But there were some silver linings as well. And some of those were that in my facility, there was hugely heightened awareness of all of the people that had hearing loss once we started wearing masks. And so in our institution, that led to a much bigger use of amplification devices and good communication strategies. And I was redeployed along with a lot of other healthcare professionals to frontline care during COVID. And certainly that led to some new practices which were employed during COVID and hopefully have been continued after. One of them was Baycrest's Pandemic Response Task Force formed these teams, TRIM teams, of healthcare professionals like myself. I was one of the first guinea pigs to use this equipment. And we carried around for the institution with us these carts. We called them T-carts. And they were basically just poles on wheels that had an iPad on them, equipped with video platforms like Zoom and FaceTime, and Bluetooth devices so that we could connect with the physicians that were off-site. And we would actually be listening to chest sounds with stethoscopes connected to Bluetooth devices that enabled the physicians to listen to them at home. So it was pretty sophisticated. They had a great Jabra microphone and speaker. But despite this, we quickly found that residents with dual sensory loss had huge problems being able to deal with this remote kind of care. And so one thing we did was we just made sure that we rounded up all of our pocket talkers in audiology and distributed them as far as we could. And we always used a pocket talker with these devices because it helped enormously. And we also use them for social connectivity with families. We would FaceTime and Zoom families, sometimes as far away as Israel, and we would use very large TV screens because we realized also that with vision loss, people just really couldn't see on the iPad screen, and it wasn't very meaningful for them. So with donations to our foundation, we were able to purchase a lot of very large TV screens and a lot of extra pocket talkers for use throughout the center. Now, for those with dual sensory loss, wherever possible, we need to try to use personal amplification technology because it can make a really big difference. Usually we think of that being hearing aids, but these are not always appropriate for people with dual sensory loss, especially because they're often dependent on other people to manage them. So we often find that using simpler, low-cost devices like pocket talkers can be a very effective thing to do, and they're much easier to manage. And particularly when we went back to in-person visiting with social distancing or physical distancing, the pocket talker was so useful because you could see that it has a very long extension cord that you can attach the microphone to, and so the speaker could still have the microphone very close to their mouth, which meant that they could still, the resident could still hear them pretty effectively. Now, because residents with dual sensory loss are so dependent on staff, we really need to embed knowledge and training into their core competencies. And so we really need to develop institutional policies to ensure this. Because if we teach staff, as Atul was just saying, if we teach staff how to use devices to care and maintain them, and when we show them just how helpful it can be to them by improving communication, then often it really motivates them to use them, gives them the confidence to use them so they don't worry so much about losing them, and that just was adding to their burden of care. Instead, it can actually reduce their burden of care once they understand how to use devices. So teaching them is really very, very important. And I've found over 25 years at Baycrest that the most effective way is to actually teach the staff, if possible, on the unit with the residents so that it's meaningful to them, rather than trying to get staff to attend group-in services, which usually are not very well attended at all. And it's really helpful if you can assign a hearing champion on each unit so that the residents know they can go to a particular person to get the help they need. There are also some excellent online resources. Hopefully you'll get these slides so that you can have access to some online resources available for staff to access in the time they have. The World Health Organization's Integrated Care for Older People recommends that we also provide people with strategies to stay connected and maintain social relationships. And in order to do that, we often have to provide the opportunities. And one of the ways that we've done that at Baycrest is we have a Hard of Hearing Club where it enables people to come together, people with the same problems, share their problems and solutions, and support one another. It's an educational as well as a social group. And in over 20 years of running that group, I've often seen how members with dual sensory loss are able to cope as long as they can use some vision to access visual cues. But it seems that when their vision deteriorates to the point where they can no longer do that, they just give up and stop coming to the group. Now I want to show you a video of one member, one long-term care resident at Baycrest, who did go ahead and use technology, even at the advanced stage of 93, she got a cochlear implant. So I just want to show you in her own words what that did for her quality of life. Oh, sorry. Oh. No, that worked perfectly before.
What was your life like before you got the implant?
Very lonely. I would eat and sleep. I always was a poor sleeper. And sit some more. I couldn't talk to people.
What was it like after you got the implant?
Oh, after. Heaven. It was wonderful. I would go to some of the meetings they had. I could participate. I was the new person.
Would you advise other people your age to take the risk of having an implant?
If they had my problems, yes. I've been lucky.
It's been worth it for you?
For me, definitely.
So I think to the extent that we're able, we also need to shift the responsibility for communication access from the individual residents to their environment and communication partners through design of the environment by optimizing audibility and lighting, by using technology, not just personal technology, but institutional technology like the loops we're using here, and to educate staff and embed hearing care and vision care knowledge into their core competencies. Lessons from the pandemic will hopefully result in improved standards of care in long-term care, including promoting use of communication strategies and tools appropriate for sensory disabilities and following principles of universal accessibility. As care providers, we can use our knowledge and pandemic experiences to advocate for this at the institutional and health policy level and convince administrators of its importance to residents' quality of life. Thank you.
Thank you very, very much, Marilyn. The more I listen, the more excited I get about all the people that I'm working with, because you guys are amazing. So now, JB Orange unfortunately cannot be here because of a family emergency today, but he has made some notes and a recording, and so our discussant Kathy has kindly taken over to actually present on his behalf today, representing the perspective of speech and language pathology.
Okay, how's that? Yep. So we have yet another discipline from JB Orange, speech language pathology. And clinically, I'm an audiologist too. Marilyn and I have worked together for a long time. So I will do an audiologist bad version of a speech pathologist. So I will take some liberties with this presentation, but it's important to recognize all the disciplines that contribute. So the emphasis of this talk, it's kind of continuing the story of education and training of many disciplines and how that could be applied by staff who are communicating with people living with dementia in long-term care. So we've talked about vision and hearing, and now we're going to dive a little bit more into the dementia that co-occurs in people who have all three. So we've heard some statistics. How do we start to understand that? And I think this is a very important slide. So what actually is communication? And some of you are taking notes or you're having transcripts prepared here, and it's about maybe getting information in this session. But communication is so much more than just getting information. In fact, the main purpose of communication is to establish and maintain social relationships. It's also good for art, it's good for spiritual purposes. It has many purposes, but what JB is pointing out is that it is not just about getting information, the transactional part of communication, it's about interaction. Okay, so we're going to kind of go more on the social side of communication in his talk. And he is giving you a little bit of information about dementia. And some of you already know a lot about this. Some of you may know nothing. In one slide, what do you need to know? There are many types of dementia. Alzheimer's is the most common, but not the only type. And what you also need to know is dementia is when you cannot live independently because of your cognitive problems. And it is not just about memory. So there are many, many aspects of dementia that include, if you look down the list, language, perception, and social cognition. And I would argue that every aspect of dementia affects communication. So this is a puzzle that we have to understand all the pieces of. So you've heard these statistics already when Walter gave Paul's talk about the Canadian Longitudinal Study on Aging, and the fact that there is this multiplicative effect of having hearing loss, vision loss, and cognitive impairment. So these things interact in important ways. And you've also heard, this is just JB recapping the data from Don Guthrie that Walter already presented about how many people are affected in home care and in long-term care. And just a reminder, Walter said this, but you know, that interRAI looks at how well are you doing when you have taken advantage of all the technology and rehabilitation and training that you have had access to. So that those percentages are the residual problems after people have possibly already had intervention. So if we counted all the people who wore hearing aids successfully, those numbers would definitely go up, for example. Okay, so JB wanted to share with you some work that he and his colleagues at the University of Western Ontario, which is now called Western University, I guess, have done for a literature review. So all of these talks, we've started with literature reviews. You know, what do we know? And sadly, you know, we know a little bit, but not enough. So he went through the typical review process of searching many databases. There's a lot of text here. I'm just going to say, you know, what kinds of search terms did he use? He used some terms that have to do with dementia. He used some terms that have to do with communication. And he used some terms that have to do with aging and long-term care and geriatric care. He also used terms that had to do with hearing loss, terms that had to do with vision loss, and terms that had to do with dual sensory impairment. So you would think, you know, how do we get all of that in any papers at all? And after searching through thousands and filtering through them, he came up with 12 studies. So you've heard enough here today. There's probably another 12 papers that people in this room have written that you'll see next year. So this is JB's slide of these 12 papers. And he is looking at what do they say about the training of staff working with people with dementia. And he has 5 different categories that may have been discussed in these papers. Communication strategies is column number 1. I'm going to skip to column number 3, which is assistive devices. I'm going to skip to column number 5, which is improving the environment. So in case you haven't noticed, there's, we have all taken an oath, and we agree that there are 3 pieces of the puzzle: behavior, technology, and environment. So those are JB's column number 1, column number 3, and column number 5. Well, what are column numbers 2 and 4 about? Well, they are about, column number 2, he calls personhood strategies. And column number 4 is empathy or attitudinal training for staff. So I would say these are the social aspects. So you can have a hearing aid, you can have a vision device, but we don't get very far if people do not have a sense of themselves and they don't have a sense of their relationship with the others who are their communication partners. So I really like these 5 categories. And you've already heard many examples of the kinds of things that were found in these papers. I also wanted to add the World Health Organization. How did they define healthy aging? They define healthy aging as older people being able to do and be what they value. So I think that's something we should all think about. How do older people with dual sensory loss do and be what they value? So we have to go into this social dimension. So these are some examples. I'm not going to read them all to you, but I will point out of those 5 columns, the first paper is blank on the last 2, the social and physical environment. Nothing said about it. The next paper, it's got a lot in the last columns, but nothing in the first column. So you kind of see the problem here, right? We're kind of getting glimpses of the elephant, but not the whole picture. This, paper that I did with a bunch of the colleagues here, we kind of go with that 1, 3, and 5 pattern. So there are kind of different ways people have sliced this pie, and you've heard from Atul and Marilyn some of the examples about what could be done using strategies, devices, or changing the environment. And then, our next speaker is going to tell you about some of her work, Kathy McGilton's work, and she is a nurse, just to give you a tip that we have yet another profession coming up. So Kathy's just about covered all 5 of these. And I kind of find it strange that the empathy and attitude wasn't there, because I know she's going to tell you a lot about that. All right, so you kind of see the connections that we're trying to build, and this is what JB has confirmed in his study.
Thank you, Kathy. And now, of course, Kathy has stolen my thunder, because here I am wanting to introduce our nurse representative onto the team. So you see the team is growing. This is the hidden message here. None of us can do any of this alone. It is an interdisciplinary event.
Thank you. Oh my goodness, sorry. To start off, I'm going to ruin this, but I want to tell you that I'm tall. I'm tall, taller with higher heels. I have a blue dress on because I'm pretending I'm swimming somewhere in the ocean. Because I think I was supposed to describe a little bit about me. I have curly blonde hair, and thank you for inviting us to be here today. Thank you. Great. So, that's me. So my work started 22 years ago. I decided to do a dissertation in nursing. And the premise of my work was, how do we bring residents closer to the staff? How do we build relationships between staff and the clients they care for? Because I know that's going to improve the quality of life for the resident, but it's also going to improve the quality of the work life for the nurse. My work always focuses on how do we make it easier and better for the staff who care for the clients, because we know with happy staff, we have best outcomes. So along this path, I've always thought about building relationships, because we know that's very important to a very effective life. And when I looked at the literature around this, I realized that a big part of that was actually around communication. We really have to be able to communicate with one another. And it wasn't till we were just talking about how many years ago, I did a study, and I invited Kathy Pichora-Fuller onto the team, and she asked me a very, very simple question. She said to me, Kathy, this work is great, and I was working with speech-language pathologists at the time who helped me understand aphasia in more details, but she said, can this client hear you? Can they see you? And I said, you know what? I didn't learn that in my nursing education. I actually don't know if this client with dementia can hear or see me. So that took me down a different path for the last 10 years. What I did learn when I went into this is how profoundly difficult it is as a bedside nurse to tease out, does this person have a problem with their dementia? Is it aphasia? Is it actually their cognition? Is it related to their hearing, or is it around their vision? Because I didn't know how to tease any of that out. And yet, what a difference that would make if I could understand that when I'm trying to provide care as a staff person. I believe that many of our clients become quite agitated sometimes because we walk into the room and they don't hear or see us. So we decided we better look at this in more detail as a group. We have slides around how important it is that we have our senses in terms of making sure we don't have social isolation. We've spoke to this already in numerous slides. But it really has profound implications for a good relationship between a resident and a staff person if we don't know if they can hear or see. When we delved into this, we also did a review of the literature, and we found that there actually are not good tools being used right now in nursing homes, in some of the nursing homes we went to. One example, when we actually interviewed a personal support worker, we asked them how they could determine if a client with dementia had a hearing loss, and you know what they said? It's often by accident. Something loud falls behind the client, and the client does not turn around. And then they realize, wow, they have a hearing impairment. And this was a client who had been living there for 2 years. So this is how we sometimes intuitively find out that there is a real hearing concern, which unfortunately happens way too late in their stay in our nursing homes. So we thought we better look at what are some of the tools that are out there that are simple and feasible, because we know that we're very busy working in long-term care, that we want a tool that we can do quickly when they come to us in admission and later, that could we actually determine if they have a hearing or vision impairment. So we conducted a feasibility test. We found 17 residents that had some sort of dementia or cognitive impairment, and of course we asked their substitute decision maker if they could participate, and we got assent from the clients. We found 17 clients, and of course average age 85 years of age. Many of them had multiple comorbidities. They had a diagnosis of a dementia or a cognitive impairment, and we actually involved hearing and vision specialists because we wanted to make sure they actually really did have an issue. So we kind of conducted gold standard tests with them, and then we also educated 3 nurses on how to conduct hearing and vision tests that we found in the literature that we thought, hey, we could maybe use in practice that could be sensible. Here are some of the hearing measures we found in our long-term care literature. One of them, self-report. Again, that works for some of our clients with earlier dementia, but it surely does not work for our clients with more moderate to severe dementia. We could review their medical history, but shockingly, there's not a lot to be found in terms of their audiology reports. Otoscopy, we could look at in their ear to see if there's any ear buildup, and of course Marilyn was on my team, so she taught me a lot about the frustration that she's dealt with, and now I understand that wax buildup is a huge problem. And we also have, whose job is that anyway? This is a big problem in long-term care homes. Who clears the earwax? And also we looked at whisper tests and the finger rub test. And again, we looked to find what are the standard ways of doing this, and often it is actually just the rubbing by the ear. Certain distances became very scientific. It was 1 meter away, 3 meters away, And just think about this. I bet you your finger rub is probably a little bit stronger or maybe lighter than mine. So you can imagine about standardization. This is a bit of a problem as well. And the same with the whisper test. It was actually a series of numbers we would have to call out. So we would say 6, 3, 2, and then we want the client to repeat that. Again, when you have dementia, can you actually remember the numbers, recall, and give them back to the client? You can already tell how these standardized tests probably aren't going to be perfect for our population. When we looked at the literature for vision tests, we came up with some that, again, we could probably use as nurses in the long-term care environment. There were questionnaires, again, appropriate for some, but not all. There was counting fingers. That was kind of neat. Could they see your fingers? And again, we would try to go 1 meter, 2 meters apart. We had distance visual acuity, confrontational fields, and we kind of left it at that. So here are some results, and I think this is why I wanted to make sure, I guess, the important piece here is 8 of our 17 clients actually had dual sensory loss. They had concerns in both of those areas, and I can tell you that none of this was charted in their medical records, okay? So this is just a random sample of 17 clients in a nursing home, and half of them had dual sensory loss. This is a problem. You'll also see that sometimes it was actually very difficult to complete the test, and this result, by the way, are with the experts. Because what we're also finding is, and Marilyn is an expert in terms of working with people with dementia, but a lot of our audiologists are not experts working with this client group, and even she sometimes struggled. But also, it depends on the day. So what you also realize is with some of our clients with dementia, you need to go back several days to actually get a good assessment, because sometimes they're having a bad day, like the rest of us, and they let us know that. So we have to come back. So it's not always simple to do good screening tests. So we have to become very flexible when we're doing this work. This was interesting because what we did was we compared our findings as nurses, and remember we trained 3 nurses to do these assessments, and we compared our assessments with our specialists. Green meant that both the nurses and the specialists were able to complete the vision screening and then the hearing screening. Yellow meant we could only do partial assessments, and red meant that actually we really couldn't complete the test. And you'll note by their scores, and the CP scores are their cognitive performance scores, that when you have a 1, that means you have your borderline intact, but actually as you continue down the continuum, 6 is very severe. So that would make sense that the clients that had sort of more moderate to severe cognitive impairment to very severe, we really struggled with getting the screening assessments done. But in nothing else, we were consistent with some of our experts, which made us feel a little bit better as nurses. They struggled, and so did we. At the end of the day, we also asked nurses, what could you use in practice if you wanted to? And they told us things like, we could use, actually they really liked using the otoscopy. It was kind of fun and different. So Marilyn trained them how to use it, except we also had to learn how to remove earwax, because that is also part of somebody's practice, but nobody really does it. Again, we need to think about core competencies and whose job is that anyway. And again, others, they agreed with the whisper test. The finger rub test was kind of fun, but they also were concerned about standardization of those type of tests. And also language. We all speak very different languages in long-term care as staff. So sometimes our accents were difficult. So for the client to understand us was also difficult sometimes when we're doing some of the whispering tests. Vision measures by nurses. The nurses really liked using the hand motion. That was simple, something that the client could kind of tell us how many fingers they could see. So that was probably one of the top measures we thought we could use for vision. So what are some of the implications? I think the major implication is we got to work on something better. At the end of the day, what we started doing with some of our clients, especially with more severe dementia, is we started creating our own test, and one of them would be we would stand behind the client and we would call them by their name. And we found that worked because they recognized often their name, and they would turn around if they heard you mentioning their name. So again, then it's related to then how loud are you asking for their name, because that's also part of the strategy. Is it a moderate impairment versus more severe? And if we move further away, can they still recognize and turn around if you call them by their name? So we're kind of thinking about what can we do that's simple and quick, so at least we can screen, because that's all we want to do, and then we need to be able to refer them to the specialist. So we are working on this. I guess in summary, we need to continue to try to use any type of devices that make communication more accessible. We need to have timely, and obviously these measures, we need to continue to do them throughout the life of the resident living in our long-term care, especially if there's an abrupt change in their condition. We have to continue to use, of course, informal self-observation kind of strategies until we come up with something a little bit more substantive. Because we know this has really huge implications for quality of life and for the care that our clients are receiving in these environments. I think my work is also focusing a lot on trying to prevent functional decline, and if we can't get our clients up and out of bed because they're not sure that we're even there to care for them, we're never going to have good quality. I guess in conclusion, I think a first step in building relationships is being able to actually understand if the client can hear or see us. And I think now, like I said, I will make sure that this is part of care while we're in long-term care homes. And that really, this work has opened my eyes to the fact that dual sensory is a huge concern in long-term care environments, and that we better do a better job of assessments and then putting in interventions to make sure we can communicate and build these relationships that are going to make us happier, make us want to stay there, and I believe will actually significantly reduce the number of responsive behaviors we see of some of our clients with dementia if we can actually tap into their hearing and vision abilities. And I think that's all I have. Thank you.
Thank you so much, Kathy. And this is also an excellent transition now to our next speaker, Michelle, who is my secret weapon when it comes to long-term care. Here's a researcher who's actually based inside of a long-term care environment, who's taught me lots about how this all works. You're in the Department of Family Medicine, so I don't know, and you're trained in statistics. I don't know really what your identity is, but I'll let you explain.
My identity, wow. Does it have to be binary? I have many, many hats. So hi, nice to meet you all. I'm Michelle Wilchesky. I'm a middle-aged Caucasian woman with long dark hair. I'm dressed today completely in beige for whatever reason, I don't know, just what came out of my closet when I was packing. And I'm holding the microphone instead of standing next to it because when I'm not a scientist or a mom or a caregiver or a wife, I do sing. So I'm very comfortable with a mic in my hand. So, okay, so I have to go like this. Okay, so the talk today, I'm going to tell you about a fun project that we're doing, which is more of an action project, because you've heard about how dual sensory impairment is a problem in the long-term care environment, that sensory impairment is a problem superimposed on dementia, which comprises the majority of the long-term care residents who live there. So I'm a professor in family medicine and geriatric medicine at McGill University, but I'm the director of the Center for Research and Aging at Maimonides in Montreal. So my office is actually in a long-term care home, a large one, 387 beds. But I am an epidemiologist by training. So this is a Quebec-funded research project that I'm working on with Walter and others, and this is the largest, so you can see that Kathy Pichora-Fuller is one of them, and Paul Mick, and a lot of the names of the people who are here in this room and are part of this presentation are also part of this project. And at the time, Atul was Walter's postdoc, which is why he's listed as a trainee. So we know that dual sensory impairment residents are a significant yet understudied group, and that there are communication challenges, and that the pandemic has exposed that there is an actual knowledge gap. Examples of what happened. So Montreal long-term care was ground zero of the pandemic, as you know. This is where a lot of the first losses happened. And in some cases, the Canadian Army, for example, had to come in, or other volunteers had to come in and sort of take over where staff was missing. And of course, these volunteers were very well-meaning, but nobody received specialized training in dementia or in sensory impairment. And, you know, there were many anecdotal stories about residents who would have, you know, a food tray brought in, and the food tray would then be taken out of the room completely untouched. And why was the food tray untouched? Well, the resident had no clue there was food brought into the room because they couldn't see it, they couldn't hear the person when they came in, and it was just sitting there, and residents weren't eating. That's just an example. So, you know, there are no standard communication training procedures available right now to help caregivers. And by caregivers, I want to be very specific. We're talking about both regulated staff, so nurses and the people who actually have professional association standing, and unregulated staff. And who are those people? Those are the personal support workers. We call them PABs in Quebec, and also informal caregivers. Families often hire private persons to come sit with their residents in the care homes so that they have an advocate, so that they have somebody to take care of their needs one-on-one. So those are also caregivers. And so our objectives, what we wanted to do, was we wanted to develop and evaluate 3 communication support training visual modules for these providers. So what was our criteria? We want it to be web-based, so it'd be very accessible, bilingual, we're from Quebec, designed for all healthcare workers and caregivers, meaning not just the nurses, but also for people who aren't professionally trained, and specific to caring for long-term care residents with sensory impairment. So the overall goals of why are we doing this? Because we want to improve care and dignity of our residents, and we also want to reduce staff and caregiver burden, because we believe that if you receive training, if you have more knowledge about how to deal with these residents, actually your work will be easier. And I do believe that to be true. So this is I'm showing a big picture of what the project is all about. It's a very broad project with a lot of different objectives and steps. I'm going to focus in here on this, which is, you know, we're going to talk about how we developed we're developing the modules themselves. So phase 1 was, well, we started off with all the literature reviews that had been done, and we put together a co-creation group. So it was a participatory process, a co-creation group of long-term care knowledge users to participate in a 15-minute online survey, and then the survey results then get presented to these individuals in focus groups, and they help us to talk about what the results were, and then that is then translated into scripts for the videos, and then we bring the video scripts back to the people if they're interested, and we then put it to production. So participants are co-researchers who test practices, gather evidence, and evaluate the research through these reflection phases. And we asked survey participants to rate a list of these predetermined topics. And how did we predetermine the topics? That's the literature reviews that were done, that were described to you earlier, in terms of their perceived importance for inclusion in these visual modules. So who were these participants? As I mentioned before, they were regulated providers. Okay, they were also non-regulated providers. So the regulated providers were nurses, physicians, LPNs, occupational, recreational, physical therapists, and social workers. So those are when I say regulated, that's who I mean. Non-regulated, those are the personal support workers, the paid companions, the military personnel, and volunteers. They were either English or French, but they had to have worked with long-term care residents with dementia. So we had 29 29 participants, providers, of whom 41% were non-regulated and 59% were regulated, and that's the distribution of who was in the study. 90% of our participants were female. They were on average 42 years old. On average had 8.5 years of experience working in long-term care, so that's quite a bit. I mean, on average, we're talking about people who had quite a fair bit of experience working in this milieu. And only 14% had received training on communications with persons with visual or hearing impairment. That's not a great statistic. So, the literature reviews brought us to 5 main topics, and we wanted to evaluate these topics because we know that with 3 visual modules, we wouldn't be able to cover everything. So we really wanted to get to the core of what would be the most important. So 5 topics. Topic 1, raising awareness of the effects that hearing and vision difficulties can have on older people. Topic 2, describing how to identify hearing and vision difficulties. Topic 3, describing the actions to be taken if there's a suspected impairment. Topic 4, instructions on how to fit, clean, and maintain assistive technologies and devices that are prescribed, such as glasses and hearing aids. And lastly, topic 5, describing alternative methods that could be used to improve communication between providers and residents with sensory loss. So those were the 5 topics that we asked about this on this online survey. So I'm going to show you some of the results. So in terms of overall ranking by topic, so I am showing a bar graph, if you can't see, and the blue bars represent the regulated participants, the pink bars are the non-regulated participants. Basically, the actions to take was by far the number 1 of importance overall. Second most important topic was communication, and the third most important topic was identifying DSI. And it's not to say that the work that these other people are doing about maintaining devices and raising awareness isn't important. Of course it's important. But in terms of what would make the most impact, in terms of having information imparted by these training videos, these were the 3 topics that were identified. So within topic 2, describing how to identify hearing and vision difficulties, more important was observing symptoms and behaviors that can indicate a sensory difficulty. So that more important than the screening tools. So screening tools, yes, important. Kathy mentioned that, there could be problems with some of the screening tools that are available. They're not standardized, and screening takes time. And when you're doing a screening, don't understand, that has to be like an organized activity. But if you're trained to sort of observe and notice, that potentially would have a lot of impact. So both regulated and non-regulated thought that would be the most important. In terms of describing the actions to be taken, so this graph, you'll notice that there's only pink on the left side. So we only asked the non-regulated the first 2 questions. We included 2 extra questions for the regulated participants. So in terms of describing the actions to be taken, the non-regulated thought it would be equally important to be noting observations that could be important to the care plan of the residents and also reporting to staff members what they observe, which makes sense. That I totally buy that. In terms of the regulated personnel, they also felt that noting observations, but of course you have to be trained on what to observe, right? So that has to be a key feature. You have to explain what you're observing and to teach them what to look for. But then noting the observations was number 1, and then equally important would be to assure that assessments lead down the line to diagnosis and proper reporting, to expedite requisitions for treatments, and referring to established protocols and integrating sensory loss care in their care plans if available. So when we do the videos for the the regulated staff, we will be including those as well, of course. And then lastly, topic 5, which is describing alternate methods that can be used to improve communication between service providers and the residents with sensory loss. Well, here, adapting communication behaviors was number 1. So speaking clearly, using slow speech, and short sentences. That was really deemed to be number 1, followed by, the regulated felt that facilitating the use of assistive technologies would be important, which is a good thing. The non-regulated were more split between optimizing the environment and having more availability of these non-prescription assisted technologies, such as the pocket talkers that people were talking about. So what are our next steps? So our next steps, we are currently trying desperately to organize our focus group. Unfortunately, people are on vacation. So we have, Walter, update. We have 5 individuals out of the 8 for the first focus group who have confirmed. We're hopefully going to have this focus group in September. And then we're going to create our video modules. So again, this is work that is collaborative, and it is not instead of, it is, in support of a lot of the other work that's being done to train regulated staff and nurses on communication tools with dual sensory impairment for this long-term care population with dementia. But it's a baby step. It's a baby step, and but a necessary step, because it's talking about the building block basics of what you need to know if you walk into a room with a resident who has dementia and sensory impairment. And I think that everybody might benefit from it, and hopefully it'll be something that will be available, it'll be useful. And of course, part of this study is also we're going to then evaluate it. We're going to find out, from the people who use it, if it has been found to be useful, et cetera, et cetera. So thank you very much, and I'll pass back to Walter.
Thank you. And also thank you for having the idea to take the microphone off the stand. I will grab the advancer from you. Thank you. That's perfectly fine. And now we'll hand over things to Dr. Kathy Pichora-Fuller, our discussant, the lady whose specialty is to synthesize things. Kathy.
So just hold on for a second. So we have 20 minutes?
Yes.
All right. And I'm thinking, do you want to run the microphone and I will use the podium?
Excellent. I have become the go-for guy. There you go. I am going to put up Kathy's picture. You have a slide or 2, I believe. Should I go to your slide? There's your slide.
Okay, so thank you all for listening and being very patient. Hopefully this made sense. You know that, we together can hopefully make some important changes, because we would all like older adults to age well, whether they're living in long-term care already or whether they may live in long-term care in the future. And so I'm kind of curious. I want to hear from you. So kind of think about your questions and your comments. Walter will bring the mic around. But I just thought I would kick this off by, this is kind of a hard topic. And it's often, a bit kind of not exactly the most cheerful topic to think about, when you're old and you're in long-term care and you've got sensory loss and dementia and no friends. And thank goodness for Marilyn's client who we saw, who had that kind of, joie de vivre no matter what. She was going to live her life. So I want to end on a positive note. And I'm bringing you, 2 examples of why we should be optimistic. And the first one was a thing that we celebrated this year in Canada. And it was a rather quick process that resulted in a reform of our standards for long-term care. And it was very clever. Sometimes I do enjoy paying taxes if they're used well. So it was a combination of a revision of the Health Standards Organization and the Canadian Standards Association. So the health standards was led by a geriatrician, and the Canadian standards was led by an engineer. So they kind of did the behavioral, organizational, technological, built environment. They did the whole package. And they did one of the most extensive consultations that has ever happened. They tried to include a large number of people who were in long-term care and their family members. And it finally was produced. And we were just thrilled because we had provided input regarding the importance of sensory care and communication in this makeover. And many of our recommendations they took verbatim. So these are not enforced legal requirements, but these are actually very good standards that actually speak to all the things we've been speaking here. So now we can point to the standard and say, yeah, you really should do this, and this is how you can do it. So it's a great moment of victory for us to at least have some kind of a plan for what long-term care should look like. The other kind of reason to be hopeful, at least for us in Canada, is that a part of the reaction to the crisis in the healthcare system is to create a rethinking of how we do health. And in particular, the primary care doctors are very overloaded, and that leads to problems in emerge. And, you know, one thing just is toppling because the domino beside it has toppled. So one of the things people seem to agree on politically is that we should have interprofessional primary care teams, so that if you have a sensory problem, the sensory professionals can do their rehabilitation. If you have a balance problem, the physiotherapist can work with you. If you have diabetes and you need some nutritional counseling, you know, we have an army of health professionals who are not being deployed to keep people healthy in primary care, which could start in a GP's office and go to home care and go to long-term care. Long-term care is in this concept of primary care. So we do have this team primary care, which has been implemented with leadership from the College of Family Physicians, and our Minister of Health has put a lot of money on the table. So where there's money, there could be improvements. So I think you kind of got a sense of how we're struggling to work together, how we hope when you leave the room, you know, you too will try to make connections and network, and we can network across countries. And at the WHO, if you've heard of the ICOPE, Integrated Care for Older People, they identify 6 domains: hearing, vision, cognition, mental health, mobility, and another category that's a little weird, but it includes things like nutrition. So there is a call for us to put this together from the WHO, you know, which will put it across for member states. The WHO has created resources for hearing care and primary care, et cetera, et cetera. So the ball is rolling. So are we picking up this ball or not? So what do you guys have to say about it? I see one person down there, Walter.
I think it's a great idea. I actually had a bunch of questions about your education programs, like how further are you going to go? Are you looking to this stuff before school or after school? Are you going to try to get it into the standardized for their schooling so they're already pre-prepared when they leave as PSWs? I know it's hard right now. PSWs are just trying to push them out the door as fast as they can so they get in the workforce, but they're not ready. It's a 6-month program. It's only 3 months of theory. Like, we don't know enough to actually go in there and do what we need to do properly for these care.
Okay, so the question is, well, we have to, basically it's a revolution, you know, like we need a flag or something. So where do you start? So education is a logical place to start, and many of us have tried to do this in our own professions and kind of failed miserably, to quote Homer Simpson. And we have to do it together, I think. You know, we are never going to learn how to do interprofessional care unless we train together and have an opportunity to practice together. And I think, you know, e-health has allowed us not all to be physically under the same roof, so that you cannot possibly have an audiologist or a vision expert in every single long-term care, but you can have a communication pathway to call in expertise. And so how do we create the connections? So this team primary care, they have had 2 calls now for grants of 2 sorts. One is to create interprofessional education curriculum, and the other is to create practice models of interprofessional primary care teams. So these are pretty short grants with expected fast turnarounds so that we can kind of get off the ground. And now the Minister of Health has put more money on it, so we will have more opportunities. So Walter, you can contact Walter and sign up, because I really want us to have a grant where we look at how all these things combine in the context of dementia, long-term care. I'm kind of thinking dementia makes more sense, because maybe a lot of people who are in long-term care actually should be getting home care. And if we take a life course approach, maybe we should actually start when they're middle-aged, before they ever get to need these services. So sign up now, because a grant is coming to you soon, someplace, for us to work together and show how to do it. And it's going to be really exciting. Kathy McGilton.
I think your question is really great. I think the question is, how do we prioritize what we need to know in school, but also once we're in the clinical practice? I don't have all the answers, but I believe it needs to happen in both. You need to at least be exposed to some of the content in your schooling in some form. But I think what happens with most education, and Marilyn, you mentioned this, we often educate our staff with workshops that nobody attends because we're too busy, or even worse, you go put it on a computer screen and you have to tick off that you've done it. And you usually do it at 2 a.m, and you ask your buddy for the answers, like, you know, I've been there. So that's not you do get then that you've done the work. However, the next problem is you have your client with dementia with 6 comorbidities who's depressed, you're not sure if they can hear or see, and you've just taken a module on here's how you should do a good screening assessment. You know what? Putting that into practice is incredibly complex, and that's what we forget. This is where you need the one-to-one mentoring. Knowledge translation is expensive, and until somebody in the government figures this out and puts the right person in place, and that's going to be someone with some advanced practice knowledge, being empathic, understanding the person, understanding their remaining abilities, then you teach that personal support work. You say, come with me, and I will show you how to do this assessment. Come with me, and I'll show you how to do the wax removal. First of all, the PSWs will never be allowed to do that. Well, who knows? I say that now, but I don't know. Right now, we need our RNs to at least learn that skill. Who knows what the future holds if we teach people how to do it properly, and there's some sort of standards. I think that's where the role of somebody like an RN or an RPN that has the knowledge can do the mentoring and help the PSW do it well. Because I think you get just a snippet of the education in the class, but then the how-to has to happen in the long-term care environment, and we have to hire people that are going to actually help and mentor the new staff coming on and how to do it well. That is what I believe has to happen.
While Walter's taking the mic over there, I will just say at the University of Toronto, there is an amazing department for interprofessional education, and the acronym is CACHE, C-A-C-H-E, and they are highly involved in this team primary care. And they have been giving webinars. All of their resources are up there on the internet. But it's like, what kinds of things do people have to learn first? Well, it's about leadership. It's about role negotiation, and how and their learning, their pedagogical approach is in context. So it's actually, learning by doing, in my take on it. So it's a new way of learning, which is, I think, what Kathy McGilton was trying to emphasize. Question over here.
So it's a two-part question. So you mentioned with healthcare professionals, nurses, and doctors, and regulated professionals, they really have no idea how to interact and care for deafblind individuals and what their needs are. They're really more focused on the pathological view of deafblind people. And so they don't recognize deafblind culture and what deafblind people are capable of and their skills. And they really just focus on what deafblind people can't do. They really just tend to take over and make decisions without any interaction with us about the decisions that are being made because of their lack of knowledge about us. And so I think there's really not enough education around that. I'm assuming that's part of the problem. So how can we educate healthcare professionals? So that's the first part of the question. And then specifically for long-term care, senior citizens, so as a deafblind person myself, I'm not really I'm not really confident in the future if I were to go into a long-term care home. I really don't feel confident that that the staff would know how to interact with me, or that they would let me be part of the decisions that are being made on for my health care. So being isolated has a big impact on healthcare, and not specifically on deafblind people. And not having access to their language, like staff don't know how to communicate using protactile or tactile language. They just speak to us, and obviously we don't have any idea what's going on. So that's a big issue that I'm concerned about for my own future.
Okay, well, thank you so much for the question. And I don't know, do you know this person, Walter? Because we can sign him up for our research and he can tell us what we should do. But I like this HSO because they involved people living with dementia. And I think everybody agrees that the only reason for the professionals to work together is in order to support the various needs of people who are not just ears and eyes and brains and legs. It's a whole person. And I think the timing is not bad, because these long-term care standards also have very interesting new content about diversity. So, for example, sexual diversity. And all of a sudden, all of healthcare is realizing that there is ignorance and there is bias, and that it is not just what happens in the four walls of a clinic or the four walls of a hospital or a long-term care. It's what's happening in society that also has to change. So I think we should have an age-friendly world, which is dementia-friendly and sensory-friendly. And there's a lot of social action and doing participatory research, like Michelle talked about. So sign up, because we need people like you to help us, because you're right, we don't know. We have time for one more question at the back.
Hi, it's Roxana from Deafblind Ontario Services, and I dream in the future world, because if you don't know Ryan, he's extremely young. And so we hope that by then long-term care will be very adaptable and very supportive of what the needs are of individuals who are deafblind. We have tried in our organization multiple times and also have had partnership funding with CNIB, Community Deafblind Services, and Canadian Helen Keller Centre to try to get education pushed out to the PSWs and the direct service staff in the province of Ontario. And the biggest thing that we face, that we all have to lobby together, is the funding that goes to long-term care. And there is no money for mentorship. There is no money for education. And we have been very creative in some of our approaches by doing little lunch and learns as the PSWs go from one session to another. We grab them and try to teach them as much as we can about dual sensory loss. But you know, it's just not enough. And there's no recognition there. So I can't say enough about that whole concept of working together and doing it collectively.
Thank you, Roxanne.
I think you are totally right.
Yeah.
And that's how it's going to, begin with small projects and then grow, and we can grow it together. Peter, and then I think maybe Kathy McGilton, we have another couple minutes.
Just a very quick question. Listening to Roxana and the early thing about education and the workshops that people can't come to because they're too busy, and the online training that I know I've done where I just set it going and click, 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 click and do the test because I'm very busy. One of the difficulties we have in the UK in care home is that the staffing, I think on average, after 3 years, it's an entirely new staff team. We have very high staff turnover, and so you're having to constantly educate the team. And I wondered if that was an issue in Canada as well.
It is.
Okay.
So I was just talking to the CEO of, we have a Canadian Long-Term Care Association, who's actually trying to, and I didn't even realize this existed because we have provincial standard, healthcare. But she's looking at it at a federal level because she's trying to influence the amount of dollars that goes to all of nursing homes in Canada. And she told me there's 30,000 vacancies right now in nursing homes in Canada, and there's no way we're going to be able to sustain long-term care because people left in droves. Our PSWs went elsewhere, our RNs went elsewhere, so we were having a very difficult time recruiting. So we have a huge turnover, to your point. So getting to know our clients, our residents, know them well, it's very hard. We also have agency staff like we've never seen before, and that's a whole other level of difficulty because that means that you don't know the staff at all and you don't actually care because you don't have to. And you know what? That's no fault to the nurses who lived through hell over the last 3 years with no support. I mean nurses, I mean healthcare professionals that went into the COVID, wards. So, but what are the solutions? I just wanted to mention family and resident councils are here to stay and will have more and more power as we move forward. This is now going to become government sort of focused, and so I'm inviting this wonderful young man. Unfortunately, if he ever finds himself into a long-term care, you have to get onto these councils. There will be opportunities to influence the direction of the long-term care home and to make suggestions because directors and administrators are going to start having to listen because patient engagement and resident engagement is here to stay. This is a new focus in Canada. We're going to have to be able to, where are your voices and how are you going to help set directions for the nursing home? And I just wanted to mention, because I was pretty excited that one of my studies made it to the big screen. What that study was about is we went and actually, I think, chose about 20 residents that had dementia and had issues with communicating. And we actually developed individualized communication care plans. Mm-hmm. And I thought they were quite exquisite. And I'm pretty sure we had stuff around empathy. So I'm going to go talk to, because my whole work is all about being reliable and dependable. So I can't believe I didn't write about it. But I'll tell you, that's a big part of what I do. And we teach staff that that's very important, is your approach to being with people. I mean, you can't get someone out of bed if you don't have the right approach. And whenever we work with someone, they said they didn't want to get up, I go, what did you do wrong? It's just the way we ask. It's the way we hold out our hands. That's how you get clients to do things. Anyway, having said that, we can come up with individualized care plans to tell people I can't see you, I can't hear you, but this is how you can communicate with me. And we used to post them at the side of the bed so that everybody could see it. Yes, did we have problems with privacy laws? Yes, and we said to the privacy law officer, well then the person's not going to have excellent care. What do you prefer? So we have to start kind of going to battle, I think, sometimes with what's best for the clients. And if you can tell a staff person that if you use yes and no responses and they're going to be able to respond and you're going to get better outcomes, then we need to do that. If this client has hearing issues and they need to make sure we use a pocket talker, then we have to do that. And we need to focus on remaining abilities. This is a very important point when our schools of nursing, OTs talk about this all the time. It's an abilities-focused framework. What abilities do we have? How do we maintain those abilities? And if the abilities are lost, how do we try to restore them? This is essential. I think the philosophy has to change because I think all of us have in the room disabilities in different ways. Some of them are not seen, but we have to highlight what our abilities are going forward. Okay? Thank you.
All right. I think we need to have more sessions like this, Walter. So thanks for arranging it, and thanks for all of you. And you know you can reach us through Walter. I'm just going to end with: has anybody here ever ordered a pizza? So I heard a geriatrician probably 20 years ago say what was her vision, for the future of geriatric care. And she said 967-1111, which is the pizza number in Toronto. And basically her point was, Dr. Wittich, will that be your usual? If Walter calls 967-1111, it knows it's Walter, and it knows, I don't know what your favorite pizza is.
Hawaiian with barbecue sauce.
Hawaiian with barbecue sauce. Doc, hi, Walter, will that be Hawaiian with barbecue sauce? And so with eHealth, maybe you put it by the bed, maybe you put it in the chart, but these days, every health encounter, people should get what works for the individual. And if we can do it to order pizza, why not do it in healthcare? So final word.
Thank you, Kathy. So I want to end on something that I find is absolutely stunning. Never mind the fact that I'm surrounded by wonderful colleagues, and thank you very, very much for all the things you do and to let me work with you. But I've also observed an interesting change that I want to acknowledge that some of you may be aware of. Now, Deafblind International was founded a long time ago by parents. And its focus for the longest time was children. And there was resistance over time to this idea that deafblind people get older, or that there are older people that are deafblind. And I am stunned and incredibly grateful to Deafblind International that we actually have a session now exploring long-term care in all its facets at this size at DBI. So this philosophical change took a while, but it is a sign that a lot of the philosophical change that we are looking for is possible. Here's one of the organizations that has done it. We have an acquired deaf blindness network. The leaders are present, and it's happening. So it's very, very exciting. I want to thank all of you for coming to spend the time with us. Go out there, spread the message, and for my speakers, I have little gifts for you, so don't go too far. Thank you very, very much. Thank you all.